So if you have not met Marilyn Bartlett, well, then this is your lucky day. She is a CPA by training, and when she was director of the Montana State Health Plan, she successfully led the charge to negotiate with all hospitals in Montana to accept a % of Medicare as payment. She is a rock star, and she's become a dear friend and colleague. Currently, she serves as fellow at the National Academy of State Health Policy, where she's helping numerous states better understand hospital finances. Marilyn will be serving as the moderator for the provider executive panel. And Marilyn, I'll turn it over to you now. So Marilyn, you will need to turn your video. There you go.
Some things I really don't do well. Gloria, thank you for that very kind and thoughtful introduction. It's great to be with you today. Your conference is phenomenal. I'm enjoying every moment of it. And I'm so impressed with Indiana, with Gloria's leadership, with the work that you have done, and you're bringing the whole nation in, which is great. And I'd like to congratulate the two recipients. I've been able to work with both of them through Gloria and just see great things that they have done. So thank you for letting me moderate the panel. Today we have a great group of providers who have shown their willingness to really step up and work with employers. We'll be anxious to talk about that. But I'd like to do a quick introduction of slides. Can you show the first slide, please? Great. Oh, this is just introducing me. I am a CPA, so you will see my focus on numbers. So I'm glad we have people like Shane to bring in the quality aspect too. Next slide. I'm going to focus on employers, as that's what this is about. And in my capacity at the State of Montana Health Plan, when we were able to save millions, my focus was as the employer, because the state is a purchaser. And the impacts of COVID-19 can't be overstated for the employers, the financial viability for both public and private. And so that's where most of my work is focusing. Employer health plans, I think at a time like this, transparency becomes even more important. How can you manage those health plan costs? How can you lower them? How can you make sure you're getting the quality that you need? Now, I am working part-time with the National Academy of State Health Policy, NASHP, and what I decided to do was flip from looking at hospital prices to start looking at hospital costs. So I've been doing a lot of analysis on those lines, working a lot with the Medicare cost reports. We have done quite a bit of work on consolidation, both vertical and horizontal, and the impact to hospital prices. And I get costs and prices. When I say prices, it's the price the hospital charges you, the employer. And then when I talk about hospital costs, it's their costs to provide those services. We've dug a lot into facility fees, and for us, we have focused more on the facility fees that are going with outpatient services, especially outpatient services that are done at a hospital-owned facility or a hospital-owned doctor's office. I developed a hospital cost tool. I'm excited about it. It uses Excel to take data from the Medicare cost report to analyze and compare hospital costs, also compute the profit or loss by Medicare, by Medicaid for that particular hospital. It calculates break-even points, and it's really been helpful. And so I'm excited about that tool. I've dug a lot into bad debt, charity care, uninsured, really recording that according to new financial accounting standards, FASB standards, where you report those at cost, not charge masters, and comparing payer mix with charity care across the board, and we're finding some surprising things. And then finally, I should have said that I'm looking at non-patient care hospital revenues, and there are numerous channels of revenues coming in, and we've done some infographics on follow the money. So that's where my focus is right now. Next slide. I don't have to reiterate, but I think that all of our presenters have, and Chris Whaley started off with that, the price is the problem. And the RAND analysis surely showed that. Well, this is the Healthcare Cost Institute that has been referenced a couple of times today in presentations. It's the most recent survey that came out looking at 2.5 billion medical claims from 160 million people for employer-sponsored health coverage. And it's interesting because you can see total annual spending per person increased 18.4% from 2014 through 2018. And while inpatient costs increased 14%, utilization decreased. So that it's the price. Outpatient costs increased 17%. Utilization did increase 3.5%. We've seen some move from inpatient to outpatient. And it was interesting, I didn't realize, I'm glad Shane mentioned that Medicare is moving some of their service coding from inpatient to outpatient. Utilization of medical services actually rose by 3.1%, which always brings me to the question of, which we'll talk about later, I never quite understand value-based. Next slide, please. So what are we doing today? We're going to talk about how we're partnering with employers to lower costs. We're going to hear from our provider executives. We're going to hear their reaction to RAND 3.0. What does it tell them specifically about Indiana and the service area that you're in? Where Gloria pointed out you're high on the facility costs, the prices, and you're low on the physician prices. So what are these providers doing, or what can they do to lower these costs to you and lower the prices to you and lower their own costs? And then we want to talk about what's on the horizon to lower healthcare costs. We heard some today from Brian about what's ahead legislatively and what are some opportunities and obstacles. So we're going to start off with each provider giving a little bit of an overview with some slides about their particular facility, their strategies, and then we'll get into the question and answer. So we're going to start off with Jonathan Nally, CEO of St. Vincent, Indiana. Jonathan, go ahead and take it.
Good afternoon, everybody. I'm having some, can you hear me all right, Marilyn?
Yes, you're a little light, but maybe I can turn it up a bit.
Please do. Can you start my video as well?
Sarah?
Hey,
Sarah?
I am asking you to start video over Zoom, so you should get a little pop-up.
Yep, start my video. There we go.
Perfect.
Good afternoon, everybody. Thank you for allowing me to participate. Marilyn, I look forward to the question and answer and the opportunity to be able to share with you all as employers a little bit about Ascension St. Vincent here in Indiana. Next slide. Ascension St. Vincent, Indiana has been providing healthcare in Indiana for over 145 years, the contiguous states, as well as several states throughout the union. We're large footprint across the state of Indiana in more than half the counties, as well as virtual access in all of them, and see patients from every county. We are quaternary, tertiary, level 1 trauma, transplant, teaching, as well as what you would define now as a true continuity of care. We have a number of specialty hospitals, critical access hospitals, a number of urgent care centers, but also a growing and continue to be robust digital platform that improves every day based on how we want to make sure we're serving every Hoosier, right care, right place, right time. Next slide, please. And so Marilyn's correct. As we've seen, U.S. health spending is projected to rise to 19%, nearly 1/5 of the GDP. And we know we've got to continue to rein that in. And I'm pleased with what healthcare as an industry has done the last several years to recognize it, the recognition of the RAND report to help drive that even further. And then what we need to do as healthcare systems to partner directly with you as employers about what necessary steps can we take to further reduce not only the cost, but increase the outcomes that we see. Next slide, please. So these are the challenges that healthcare as an industry has faced the last several years as we work to reduce the cost of care. When you understand healthcare as an evolution, intensity of services and advancements in medicine have helped to increase the cost of it. But thankfully, we've seen greater outcomes from that. 60% of our inpatient costs do come from wages, salaries, and benefits. Inpatient pharmaceuticals, outpatient pharmaceuticals, and prescription drug prices and medical device spending has seen an increased spending over the last several years, contributing to that increased cost to healthcare as a system. And you've seen a number of health systems have tried to take charge and been successful. And what does population health look like? What does continuity of care improvement look like? How is direct to employer? And the investments that we need to make so that we can continue to drive increased change to the country and the population as a whole. And then the most recent data that we're seeing is that 20 to 30% of healthcare costs are from administrative requirements and the administrative burden that has come from healthcare operations in the last several years. And it's one that we continue to work with the administration. We've seen some incredible movement in this current administration on how do we reduce those administrative burdens, and we've been pleased with that movement thus far. Next slide. So what we're experiencing now is disruption, transformation, and the progressive aspect to it. And at this point in time, there's no better time for health systems and employers to work directly together on how best we can improve what you need as a service and a benefit to your associates and your employees, as well as how do we drive down that cost of care throughout. And I know there's a lot of solutions that you'll see in the panel, and I believe they're going to carry an opportunity to benefit for that. But here's some elements that we believe are points that can help you as an employer continue to drive this change positively for your organization. Next slide. Several of you, if not all of you, work with a broker for your healthcare benefit package. And as the years have gone on, we continue to use that service. But I would say to you, utilize more of your relationship with your broker. Continue to deepen that relationship with your broker and work on innovative ways that are not complex, but how you can increase your outcomes and improve them, as well as decrease your costs. Truly understand, either through your broker or directly through a direct-to-employer company such as Ascension St Vincent and our employer solutions, to see what is your data showing and how do you appropriately understand a true benefit design change and evolution over several years. There is a lot of information. I appreciate Brian talking about that earlier today, but employers moving to tiered or narrow or preferred networks can absolutely decrease your cost of care. I know that's difficult, but making those necessary changes can see decreased costs and improved outcomes to it. Bundled payments. You can work directly with a healthcare system such as Ascension St Vincent and understand your data to see how can we take certain clinical service lines and cost those out based on the population that you have, the goals that you want to see, and then how do we work together for those. And then outcome-driven on-site clinics. We've got Ascension St Vincent has more than 80 direct-to-employer customers and companies in the state of Indiana. Some are local, some are national, some have a small footprint, some of them have a national footprint, such as Fiat Chrysler. But what we've seen is the more we can have that partnership of an outcome-driven on-site, near-site clinic, we can together, holding hands, not only decrease the cost, but we can improve the outcome drastically. And then one of those wellness initiatives is part of benefit plan design that allow you to work directly with your associates on decreasing the cost of care and improving outcomes. But more importantly, what we find is when we have a healthier workforce, we have a workforce that is more positively in tune in driving economic benefit because they are a stronger individual in the community. And when we see a community improve, we see health outcomes improve that come along with it. Next slide. For Ascension St Vincent, we have based all of our work the last several years in this administration of right care, right place, and right time with the right cost. And we know we've had success with that directly with our employer customers and contacts. And for us, it is, yes, the quaternary, tertiary, the highly specialized care is trauma and transplant, but we know the vast majority of care is done in virtual settings, primary care settings, wellness, advanced screenings. How do we work collectively holding hands to help your employer workforce drive down the unnecessary need for utilization later, because we've worked stronger together on the front end to make sure that our community-based care settings and partnerships are helping to find those issues earlier, which we know can have a much more positive outcome globally with it. Thank you very much. I appreciate sharing a little bit about Ascension St. Vincent and look forward to the other panelists sharing their presentations as well.
Hey, good afternoon, everyone. This is Ryan Catignani. Firstly, I appreciate you guys making accommodations for me as a non-Hoosier coming into your conference. So thank you for that. I'm supposed to be the Vice President of Managed Care Contracting and Accountable Care Services at Beaumont Health, but lately I've been doing anything but. I've currently have the accountable care organization of our system reporting to me, as well as I serve as the executive director of Beaumont Care Partners, our clinical integration network, which is the largest physician organization in the state. I also head up Beaumont Employer Services, which we started about a year and a half ago, which is a unique arm of Beaumont Health, which kind of just like Jonathan was saying, reach out directly to the employer community and create a more direct relationship with the employer community without necessarily having to involve the TPAs and insurers. Next slide, please. Because we're not an Indiana system, we'd like to let you guys get to know us better. Beaumont Health is Michigan's largest health system. You can see the numbers there. I don't have to read them to you. But in addition to the numbers, we also have about 30 urgent care clinics that are Beaumont branded in Southeast Michigan. And quality obviously is very important to us. The recent U.S. News and World Report rankings had 5 to 7 of our hospitals ranked within the top 20 in Michigan. Also, our Royal Oak and Troy facilities were among only 3.7% of America's nearly 4,500 hospitals to earn national rankings in multiple specialties. And as you've probably seen in the recent 3.0 RAND release, we've got more than a few quality 5s and 4s on the list in Michigan as well. Next slide, please. I don't need to tell you guys this. This is right from RAND 2.0, and it's what everybody's been saying all day, including Maryland in the kickoff. There's a cost problem. We've got a cost problem in the state of Michigan, which probably every employer, as well as our largest health insurer, would tell you. As the largest health system in Michigan, we'd acknowledge it as well. The question really becomes, what are we going to do about it? In order to do something quickly, you've got to be well positioned in order to do something quickly, and that's being well positioned could mean several things. For Beaumont Health, I'll spend the rest of the presentation showing you how we're well positioned now and using those advantages of being low cost, high quality to be able to accelerate initiatives that we hope will ultimately move the needle quickly. And I'd also, kind of how this works into, this conversation with you all, is the introduction of this concept that I'm sure you're all familiar with, known as domestic medical tourism, which essentially means, for commodity services, even surgical services now, it's not an inpatient stay all the time, as evidenced by, again, Marilyn had noted, the CMS recently removed a bunch of services that were historically inpatient only and moved it to outpatient, where even the CMS acknowledges that those services can be done efficiently and safely on an outpatient basis. And so really, with a state just north of you all, and seeing where we plot on the RAND study, and really as evidenced by other publicly available information, which we'll get to in a minute. Michigan really does become a low-cost option for you all, if you were willing to make the trip. Next slide, please. The first way we're well positioned is, as I mentioned, the Beaumont Accountable Care Organization does report to me. We've been in the Medicare Shared Savings Program now. We've just finished up model year 7 in 2019, and actually the CMS just released the embargo on those results, so I'm able to share an additional bar with you guys here in a minute. But for those of you who are unfamiliar with the Medicare Shared Savings Program, it's essentially managing money on a budget as a healthcare provider. The CMS provides us a cost target, by a beneficiary that's assigned or attributed to our physicians. And it's on us to manage the care provided to that individual and ultimately the population in aggregate to that aggregate benchmark. If we come in underneath, we produce savings, we're able to share in that with the government. If we lay an egg and we blow past that cost target, up until very recently, it was an upside only deal, but in performance year 7, we did actually start taking on downside risk. So from here on out, if we lay an egg, we're on the hook to pay some of that money back to the government. As you can see, we've performed very well in the Medicare Shared Savings Program in all of our years. And as I said, CMS just released the embargo. And so even in performance year 7, in spite of being at downside risk for the first time in our contract cycle with the CMS, we still were able to produce $27.8 million for the government. 14.2 million of that is shared with the ACO to be distributed back to our plan sponsors and physicians. We boast a quality score of 92.17, which is incredibly critical in order to retain the savings you actually demonstrate and earn. And in total now, with this recent performance year, throughout all of the years we've been in the Medicare Shared Savings Program, we've been able to produce $161.3 million of savings for the government, and we've shared in just over 74 million of that. Next slide, please. Here's just a little bit more on the rankings. We've been number 1 in Michigan for a while in relation to the other ACOs that are Michigan-based, and we look at that ranking through the lens of savings rate, as well as the amount of savings earned in dollars. This performance year 7 was no different. We continue to be number 1 in Michigan, and actually we also ranked number 17 in the country in terms of savings rate, and number 18 in the country in terms of savings earned. That's good enough for the 97th percentile out of 541 competing ACOs. Slide 5, please. Another way that Beaumont's well positioned is we just like Jonathan had mentioned, we're very familiar with bundled payments. Again, kind of spending medical dollars on a budget. We do participate in the CMS BPCIA program. That is the Voluntary Bundled Payments Program. We're in it in a big way. When we initially entered the program in October of 18, we took 92 bundles across our 8 hospitals. We had a program size of about $306 million that are totally at risk. It's a 100% at-risk program. So again, if we lay an egg, we owe all of that egg back to the government. We've been able to do very well in that. And it's interesting to note that these bundles are not just, kind of everybody does orthopedic and spine, right? These bundles are inpatient and outpatient. They're also medical, surgical, elective, non-elective. So, whereas we participate in lower major joint replacement bundles, we're just as much on the hook for sepsis and UTI bundles as well. And all of our hospitals, as you can see, participate in some form or another. So, again, we as a health system believe in the journey to so-called value-based care. And we believe in episodes of care as a transformational payment methodology, and we're ready to double down on that. So this slide shows you that through the most recent reconciliation period, that we're running about a 4% savings rate. That's actually after the CMS takes a 3% guaranteed haircut to our cost target. So the CMS makes sure that they get at least 3% back on this program. So we're making 4% instead of that, or in spite of that, and on top of that. And that's good enough for almost $9 million in savings in these episodes. Next slide, please. I should also add, we also, as Michigan's largest health system, we're also one of Michigan's largest employers. And so, we have a 50,000 life self-insured health plan, Beaumont Health Employee Health Plan. And, a lot of these things that we talk about, the ACO concept, the shared savings concept, the bundled payments concept, we actually incubate within our own employee health plan. And so, just like we're in the voluntary bundled payments program for the CMS, we actually also monitor these similar bundles on our own employee population. Give you an example, we monitor lower major joints on our employee population. Just this past year, we monitored 165 of those episodes. And through our optimization protocol, we were able to save about $800,000 just on those episodes, DRG 469, 470, and just on our employees. So it gives you an idea of the magnitude that can be done when you're looking at care episodically instead of on a per click basis. This is interesting. As I mentioned before, our low cost, high quality care, especially on an episodic basis, is well evidenced, not just in RAND. This is actually from our state's largest payer, Blue Cross Blue Shield of Michigan. What they did was they took 140 outpatient episodes and they combined them. So that would include, and earlier there was discussion about, even though you go to a hospital for certain services, there's also a professional bill in there. There's what we call hospital repair bills, that includes pathology and anesthesiology. So these episodic costs include the surgeon's cost, includes anesthesiology, pathology, radiology, whatever may be in there. And it tracks it sometime post-discharge as well. So if there's therapy or skilled nursing or home health, 10 days after discharge, it tracks this as well. And so really what this shows, again, this isn't our data, this is Blue Cross Blue Shield of Michigan's data, that at least on this knee ACL repair, you can see where we compare to the other hospitals in our area. And there's also some Ohio-based hospitals in there as well, and some very well-known ones at that. And if you take, I could have attached 139 other slides for the 139 other outpatient episodes, but I promise you they all chart like this. And so it's a good story for us to tell when we're going out to employers, because we're not throwing our own data back there. We're actually using others and letting others' data tell the story for us. Next slide, please. And so, what it all comes down to is, when we formed Beaumont Employer Services, we kind of felt like, hey, we've got good successes through the ACO, through our clinical integration network, and how we manage our own employee population, not to mention the episodic successes that we've had through CMS's BPCIA program. So let's take that out to the employer community. And we don't want to play telephone through the insurers or the TPAs. We want to go out to the individual employers, big, small, and middle, fully insured and self-insured, and ask them what is important to you. Because what's important to the insurers or the administrators isn't necessarily what's important to employer A and not employer and not the same as employer B and C. And so we have, we're nimble, we're flexible. As you can see, we offer a suite of solutions that we had to be very nimble on very recently with the COVID crisis to be able to pivot and offer molecular and antibody testing, sometimes on site, sometimes drive-through, sometimes at our own labs. But the whole point here is that we're trying to take the efficiencies that already exist and are well evidenced via things like RAND and Blue Cross Blue Shield of Michigan, take them out into the employer community and find ways that we can work best together. Because the best way, in my opinion, to move the needle is, one, to have a willing provider to work with you, and two, a willing provider that understands your guys' pain points and your hot spots in your own medical expense report, and not just because Blue Cross Blue Shield has said, hey, look, we've looked at everybody and this is what's important to us. We want to know what's important to you. Thank you.
Good afternoon. My name is Sherry Bruchery. I am the president of Integrative Care Partners, and very excited to talk with you guys today about the role of independent physicians in affecting the cost of care. I apologize for the lighting and the video in here, but we'll keep going. Next slide, please. You know, at a time that our market was shifting significantly from independent providers and hospitals working together, we started moving, of course, towards more employed providers, hospital employed providers. The advisory board company came in and spoke to our group of independent surgeons. The message that the advisory board conveyed to us and was seeing nationally is that the same thing that we were feeling locally, a recognition that many of the services can be done in lower cost settings at the same or better outcomes. Employers are taking a bigger role in directing the care of their employees, similar to how it was more towards in the 90s and resurfacing again in the last several years. And that physicians actually are pretty darn good at managing care. Next slide, please. So historically in our market, as we work together with hospitals and physicians, but we worked independently. Over time, again, as in markets across the nation, primary care became employed in the 90s, and then more recently, the specialty care that utilizes hospital services like cardiology, orthopedics, various surgeries became the goal and the aim of the hospitals in our market. First, they started by recruiting the independent physicians that were already there, and then they augmented this by bringing new physicians in of like specialty in the market. The result was the same. The hospital-employed primary care providers were directed to refer internally, resulting in a decrease in referrals to the independent specialists. This is driving up the cost of care in our market, so employers are beginning to access medical tourism to bring down their spend, which is then driving more patients away from the independent providers who can actually affect change in cost to those employers. Now, understanding that there are physicians who do prefer an employed model, there are also physicians who prefer independence. It is this latter group of physicians who came together to build a model focused on doing the right service at the right time in the right facility, perhaps defined a little bit differently from what the hospitals may define it. This organization is called Integrative Care Partners. We are a clinically integrated network of independent providers. Next slide, please. This slide just gives a few of the examples of the lower costs we're able to provide as independent providers, keeping patients out of the ER, the outpatient surgery at non-hospital owned facilities, and then of course, imaging. Now, I will say that about a year and a half ago, we did publish online the cost for MRI and CT with a cost calculator. We actually received calls from the health system saying, how can you do this? How can you have rates that are this low, and how dare you basically put them online? It is what we are doing, and what we are doing as part of this organization. But the one that really shocked me is the footnote there at the bottom. This is an actual example from the South Bend market. And the patient is a medical professional, so chose to have the services done at their employer's facility. The cost of the hernia was $42,000 when this could have been done at a freestanding ASC for about $4,000. So the question comes up, what were the complications? Did the outpatient go to inpatient? What caused this driver? According to the physician and to the patient both, again, medical professionals, there was nothing that indicated this extreme difference in cost. No complications. The patient was an outpatient. So we don't understand why that huge difference in cost, and this is an actual example. As I identified just a minute ago, there are skeptics about what we are doing. So we see it both from the health plans. We see it from actually some of the brokers in our community are a bit more resistant to it. We see it from other providers saying, can you really do this? The answer is yes. There are brokers, there are TPAs, there are employers who are willing to look at delivery of healthcare a little bit differently. Tradition resists innovation, so this is expected. We hear your network is too small. Well, when you have a tiered network or you have a bundled agreement, that causes us to see it differently. The brokers are seeing it differently, the employers are seeing it differently, and some TPAs are seeing it differently. Next slide, please. So as you can see here, this is just an overview of the specialties that are a part of Integrative Care Partners. We have a full range, we cover probably 80 to 90% of what the community medical needs are. We do it at a lower cost simply by virtue of the physicians making the decision with the patient based on what is the right place, the right thing for the patient to do, rather than on other competing forces. We don't have people who are checking with them saying, why did you refer someone to this particular system, our provider outside of our system? We are encouraging the dialogue between the physicians, between the patients, to choose the right service. In a nutshell, this is Integrative Care Partners, and we are looking forward to talking more about what we are doing today. Thank you.
So Marilyn, we welcome you back on with your video and audio, and I think you are going to have a Q&A session now. And so if all of the panelists can turn their video and audio on, then we should have all of you. There you are. Okay, I'll go away now.
Thank you so much, Gloria. This is what a great panel and what a variety of offerings and work with employers. So we've got the whole gamut to talk about here. I want to start off with kind of taking from the RAND study along with some of the things that come from your unique organizations to kind of pull some things together. Jonathan, I'd like to start with you a little bit. Now, on the RAND study, it appears that Ascension is more towards the high end of the cost. And that brings up the issue of consolidation. And the studies that show consolidation definitely does add the cost. I'd like your perspective on that and the RAND results as well as the issue of consolidation.
You know, Marilyn, it's a great question. And I'm glad you brought up and the chance for us to really talk about it, because I talk about it really not just for Ascension St. Vincent here in Indiana, but Ascension as a whole, one of the largest faith-based health systems in the country. I believe in free market, and with free market, I also look at the necessary need for consolidation. And I take the example of what we had in here. My predecessor in Indiana, he consolidated a lot of healthcare in his time here towards the latter part of his career here. And my role with it was, how do we optimize it? And so, you know, in Ascension's mindset, consolidation, is it really the cause of high prices, or is it the work that you do with consolidation or the lack thereof? And in our case, it's the work that you do to optimize. How is it you reduce unnecessary costs? How is it you take out duplicated costs or unnecessary wasted aspects of it so that you can deliver that directly to the consumer or a specific community? Because really, at the end of the day, with it, the idea behind consolidation is remove unnecessary beds, testing mechanisms in a certain market. But then the other aspect of it is, how is it through that you're setting up a continuity of care that is not just a footprint in a state, but it's nationally as well. And we've got a number of not only local direct to employer agreements, but we have a number of national clients as well that look to that. In Ascension, let's take heart transplant. In Indiana, Ascension St Vincent is the 8th ranked heart transplant program in the country. And so with it, we do heart transplants at 1 location. We do high-end complex heart procedures at 3 locations at all 20 St. Vincent locations throughout the state. We're not going to do heart transplants in Kokomo, Indiana, or at St. Vincent, Ascension St. Vincent, Clay in Brazil, Indiana. But we've got to do the right patient, right place, right time to make sure that the outcome is driven as well as the cost. Ascension's no different. Ascension, in the numerous markets that we have around the country, we don't have heart transplant, but in just a few markets. And we work to consolidate those, and we work with our employers as well. So I believe consolidation is appropriate. An aspect that I would say we should drive attention to is the role of private equity in healthcare. And while I'm a proponent of private equity in a number of industries and what it does in free market, I think we could put a lens on what private equity is doing to actually increase cost through consolidation everywhere, especially with physicians. And I think the burden that it puts forth on physicians related to what then they have to do to earn back that high payment they've received on the front end, because a private equity group isn't held to the same anti-kickback STARK standards that a healthcare delivery network is. So I believe that plays a role in it. The other piece to it related to consolidation is the right health system, and this is where I ask you, the employer, to make that question arise is, through consolidation, what have you done to decrease costs? What have you done to bundle services to increase outcome? And then force a health system, a broker, an insurance company to show how is it consolidation can you prove that you're making that mark of better outcomes at a less expensive cost to you, the employer who's providing that benefit to your associates.
Thank you. You bring up some good points with that, the private equity and the employer, but putting that pressure back on, asking, what have you done to lower the cost? Great. Ryan, I want to ask you a couple of questions. Now, you're from a neighboring state, and as you noted on the RAND report and others, that your costs are coming in fairly low. And so we've had a question from one of the audience that says that it's been repeatedly, that there was a recent paper by the Alterm Institute comparing Indiana and Michigan. And in it, it noted that Michigan's high level of per capita hospital utilization offers a cautionary note. And while the prices may be low, that needs to be addressed. And I want to ask you about that. How would you respond to that?
It's fair. Utilization can't be discounted when you look at the value equation. And so I think, how I would respond to that is, first of all, Michigan and specifically Southeast Michigan and Detroit, are kind of, they're slow off out of the starting gates because of health inequities, health disparities, social determinants of health, access to care, all that kind of stuff that would go into, inherently kind of a sicker population, one that would be more likely once they need care, right? Because they don't typically seek it when they don't need it. When they do need care, to need a lot of it then. And so I think that, it's not necessarily where we've come from, it's where we're going. Again, if you look at our own ACO, which covers Medicare beneficiaries, about 26,000 of them. When we started this journey about 8 years ago, we had one of the highest benchmarks in the country. And that would be indicative of exactly what you said, both high cost, if we're not high cost, we've got to be high utilization. Something's got to be pushing that benchmark up. And I think what we've absolutely seen over the years is, as we've excelled and succeeded in the management of those patients, a lot of them with chronic complications and chronic comorbidities, we've been able to normalize the benchmark. And in fact, in this last performance year, when we started going to downside risk, the CMS restated our benchmark and moved that benchmark down $2,000 plus per beneficiary. That means that the cost of care, right, cost and utilization included, is normalizing and in fact trending downward in Southeast Michigan, at least around the population that are attributed to us and we manage. And so again, I think it's a fair point, but I also would think that Medicare Shared Savings Program benchmarks, as well as the episodic cost of care that's illustrated and evidenced in a lot of the studies that we've seen, as well as in our own research, would say that I think the way to tackle utilization and cost at the same time is to get away from the per click fee for service model and get into a payment model that addresses care on an episodic basis, so that you can address overutilization, potentially duplication of services, unnecessary services, because they're all bundled in that episode. If you overscan or you rescan when someone's had an appropriate scan 6 months ago, then that's on you, and that's all going to roll into your bundled payment. And if you overspend, you're at risk for it. That's why we truly believe at Beaumont that episodic care is really the most transformational payment model out there.
Great, thank you. Sherry, I wanted to ask you, now you come from a very different model, and when I saw the results that Chris presented today, and I saw where Indiana fell with physician reimbursements, fourth from the lowest, and with the facility reimbursements right up there close to the top, and I'm curious to hear your reaction to that.
Oh, and I did have a reaction. Yes. We have seen, of course, so much vertical integration, and in our market, we have seen that that's been an acceleration of the cost through employment of the physicians, both by recruiting out of the independent groups and bringing in the duplicate specialties. And what we find with these higher rates that the hospitals are able to get from the health plans, they are able to pay rates to recruiting physicians that far exceed what independent providers can pay. And it's probably up in the 90% range, where we may, or pushing a little higher, where we may be able to pay in the 50% range. That's an issue. That's a problem for not only us to be able to recruit new physicians in, but it continues to exacerbate the issue of the cost of care to the employers in the market. And then, of course, with the insurers being complicit in this by paying those high rates, what we're also seeing is how they are not willing to pay for the freestanding facilities. So a prime example of this was in Indianapolis a few years ago, with the imaging centers. You saw there were a number of independent imaging centers throughout the area. It was at a time when legislation nationally was saying, gee, don't send things to physician groups, send it all to the hospitals. Let's get everything into the hospitals. So the insurers were continuing to pay the hospitals at a higher rate and paid the freestanding imaging facilities at a lower rate. What happens then is that you get what we saw today in the RAND study, where you've got $3,000 MRIs, where you could get that same MRI less than $1,000 at a freestanding facility, but yet the insurers were not willing to pay a sustainable rate to cover the cost of operating, much less the reinvestment in equipment, while then continuing to pay the very high rates to the hospitals. So the result of that was freestanding providers either sold to health systems or they closed. Again, you see the cost of care continuing to go up. The scenario continues to play out for ambulatory surgery centers as well. The payers will argue over paying for something like implants. So they pay the hospitals for implants, but then they may argue with the ASC about paying for that same implant, which they know needs to be covered by someone. And they're leaving it either for the patient to cover, which then will push the service to the hospitals, or it goes uncovered and then the ASC is paying for it. This also happens in I've already mentioned imaging, but also in physical therapy, where physical therapy has proven that it can delay or prevent, appropriately delay or prevent surgery, and it's also known to prevent or to improve outcomes. And yet, the rates that the health plans are willing to pay for physical therapy, for freestanding physical therapy, is obscene. It is not sustainable, and yet in the hospitals, the hospitals get the higher rates. So that's why in South Bend we made the determination among there are 4 well-known independent groups. We've added additional groups, but 4 independent groups that made that commitment that we can do this better. The key to this is, though, that we have to have primary care. With the hospitals, of course, they have employed the primary care, and we have seen that dwindle over time with those groups that are just single specialty or just specialty type groups. So having a group of primary care was a part of ICP was absolutely critical to make these changes happen. And it's important to note here that you have to have willing partners. So over time, the market hasn't necessarily been ready to do this over time, but over the last couple of years, we have now embraced this as independent providers to say, yes, absolutely, we can do this differently. And again, nationally, there is this feeling that all physicians are going to become employed by hospitals. That is not the case. That is not what the trend that the advisory board is seeing. And it's also not a necessity for these providers. There are other options.
Thank you. Yeah, that definitely is true. I'd like to go to some of the questions that are coming in and just ask any of you who would like to answer this. A question came up about actually with vertical integration, when systems are basically purchasing primary care practices, purchasing the physicians, then the rates negotiated with insurance companies are higher. What do you have to say about that? Now, we've done quite a bit of work on that. I did when I was at Montana Plan, and then we've been doing some at Nashby, and we see the rates going up, and a lot of that are the facility fees coming in for outpatient services for providers. But I'm going to ask you, Jonathan, talk about that, because you're probably in the position of having that question answered.
Regarding just transparency in general, I think is really what it comes down to. And you're right, when you talk about posting prices, understanding prices, Sherry has a great point to it. And again, I go back to it. This is advice I give to you all as employers related to this. Posting prices is a great first step. It's not anything that we believe can carry the day, but it leads to how is it we're transparent. And I give a lot of credit to our past governor, Mitch Daniels, who's now the president of Purdue, who's carrying that on there with the Anthem Health Sync agreement he has with Ascension St Vincent as the anchor, where it was, what are those prices going to be for certain services? When he did that as governor with the HIP plan, and then what now Vice President Mike Pence has done with governor with HIP 2.0 with Administrator Seema Verma on how does it we look at price transparency and understanding that. As employers, you should ask those questions to ensure that health systems are providing that transparency related to it. And in addition to it, Sherry's got a great point about physicians. When we're understanding physicians, there's a different market between Michigan and Indiana related to that. Physicians will move to where there is option and choice, as well as what agreements look like. And you as employers should ask those questions about how do you incentivize? Are they quality-based contracts? Are they incentives? And what are those incentives based on outcomes driven? And then you get an idea of what's the model and the intent of that health system and providing that primary care with it. And so when you look at transparency, costs related to that are just one part of it. with the data that you have as an employer, you have the ability to take that data set, work directly with a broker or a health system to understand that, break that data down and see what is it we pay now, what are those costs of those charges, and how is it you can drive a better rate to that is also bundled in with an outcomes improvement, as well as what is that overall cost savings that you can see year over year. We've had success with that with a number of the direct to employer relationships we have with Employer Solutions, Carmel Clay School District, Zionsville School District, Fiat Chrysler, and Kokomo, which is a national employer, the Heritage Group, because we work specifically with them on what is it we have to do to improve your data, the costs associated with that, and then the outcomes that we associate with it together, not just in that, but what are the plan design changes that you make as an employer? And so, again, I further work to empower the employers to do that. And I know Gloria's brought that up a number of times, and I couldn't champion that message more than she has, because I believe wholeheartedly that you as employers hold so much in being able to bend this cost curve in the right direction and improve your outcomes.
Another question I'd like to ask the whole group, and then I base it just mainly on my experience. I found it more beneficial to go directly to the hospitals to negotiate, to go directly to the systems. Now, maybe I could do that in Montana because we have 11 acute care hospitals, which is not as much to negotiate with, and we have 48 critical access hospitals. But I found that, and I got the feeling from each of you that you're willing to do direct contracts. So Ryan, I want to ask you, you being in a different state, your willingness to do direct contracts with employers too.
Yeah, I mean, that's what we do. I mean, that's why Beaumont Employer Services was created. And, you know, really our flagship offering is the Episodes of Care program that I've been talking about. You know, we've taken the successes that we've learned over 2 model years and then almost 3 model years of the BPCIA program. We've taken that rules logic and the funds flow model and we've commercialized it to a working population. And we've got about 3 dozen commercial bundles, again, across medical and surgical specialties that we are willing to go at risk for. And you know, it's not just procedurally based. We have episodes that are based on diagnosis. So lower back pain, for example, you know, where you have hundreds of different treatment regimens and potential paths. You know, we're willing to go at risk for, and again, be incented to you know, utilize and spend the healthcare dollar more wisely. Same thing with
let me ask you a quick question. Would you, Beaumont, be willing to do direct contracts or with the Inform as a multiple of Medicare rather than a discounted price off a charge master?
100%. In fact, you know, the vast majority, and I'd go so far as to say, you know, into the 90% on an inpatient basis, we're already doing that. You know, and outpatient is kind of a payer by payer thing, but you know, we routinely make the transition from a discount off of bill charges to a fee schedule or case rates or a percentage of Medicare for APCs. So the short answer is 100% yes.
Thank you. I'm going to ask you the same question, Jonathan. What about Ascension? Would you do contracts as a multiple of Medicare? Oh, you're on mute, I think.
Sorry about that. Absolutely. There's always a basis you can use based on Medicare. And for us, when you even look at ratings and outcomes, we still believe Medicare 5-star rating is the best and most comprehensive way to look at a health system or outcomes based on service lines. But related to Medicare pricings, sure. What the avenue that we like to move forward with even differently is if we as a health system in our employer direct services can understand an employer's data about what they're currently paying, we're happy to line that up as related to a percent of Medicare. To us, we like to go even deeper than that as just a percent of Medicare, because We believe we can actually show year-over-year improvement with benefit plan design. We can show cost savings about where is it you'd like to go, how does it fit globally into a more complex benefit plan design structure. And so absolutely looking at it as related to a percent of Medicare works, but to me, that's just the starting point. You can go much deeper and you could be a much better service versus where an insurance company, I believe they have an opportunity to be much more transparent with employers through their brokers to understand what is that strategy related to it versus just a cost, a dollar amount.
Yeah,
Great.
if I may just real quickly, I couldn't agree more with Jonathan's point, and I just add that the next step for us, again, I agree with him. It's just the tipping point, but I think again, value of episodic care, is and this is where studies like the RAND study come into play, right? Because if you understand where the market is paying on average, and where a certain facility, right, and a certain physician group or surgical group fits within that scatter plotting, then you can start making targeted decisions around the spending of healthcare.
We've got 1 minute left, so I'm sorry to cut you off. I want to go back to Sherry for the last question that's along this pattern. Sherry, a question came in about the small employer. We've been talking about direct contracting and the leverage that might come with that. What about the small employer?
I think there's an opportunity for a small employer in everything that we're doing and talking about today. One of the key places that a small employer might be able to work with is through their employer, through their broker, to see what might be done as a bolt-on with a network like ours, so that we sit on top of a plan that is already in place by the insurer as a narrower network, or even as bundled rates for that employer. There are, in our market, there are some smaller employers that are actually going towards a self-funded because of what we've seen happening with rates in our markets, even with utilization not necessarily increasing, but rates continuing to increase. So we're seeing some of that happen in the market, and we are a very broker-driven market. And so I think it's really important for that component to be included in. And yes, the transparency on that, we actually just went through that ourselves as we were looking for new brokers, and it's a lot of work to get to that transparency. Probably easier though than to get to the transparency on the healthcare costs.
Well, I could talk to you three all day. I'm learning so much. I really appreciate it, and the time that you've taken, the work you've done to put this together, to speak to the employers on this session. And so I'm going to turn it back to Gloria, and Gloria, say thank you.
Well, thank you, everybody. I really appreciate you taking the time. I agree with you. Now, I think we're taking steps here. I do really like, I love to hear that everyone's talking about episodes of care, bundled payments, direct contracting. These are all strategies that are really focused on sharing. So thank you so much for taking the time to share your thoughts with us.